Welcome to the Physician-Focused Payment Technical Advisory Committee's third series of public meetings. We formally go by PTAC. We're pleased to have you all here today. In addition to the members that are in the room of the public, we also have some folks on the phone and some folks live streaming as well. We'd like to thank all of you for your interest in today's meeting. In particular, we'd like to thank you and the stakeholders for the submissions of the models, especially those who are here today in support of their submissions. Your hard work and dedication to payment reform is truly appreciated. I'd like to make a few quick acknowledgments. One is to the staff that you see supporting the committee, some seated at the table, some others in the background. The work that we're doing is very laborious. And they make the work a lot easier for us and help us get through tremendous amounts of material. I'd also like to acknowledge the folks on the cameras and the microphones. They make it look easy, but we've been in circumstances where it hasn't always worked, and we really appreciate the talent of the folks who are helping make this meeting come alive for everybody. We're going to go ahead and start, but before I do, I want to make sure that people remember that what you're going to see today relative to our discussion about these models is the very first time we as a committee have discussed them in any way. We have proposal review teams comprised of 3 individuals. They work very closely with the submitters, and they talk amongst themselves about the model, but the full committee does not deliberate in any way or discuss these models prior to today. So what you see in front of you as it unfolds is really live, as our thought process as we consider and hear and retain the information. So with that, I'd like to turn it over. Our first proposal today is the Advanced Primary Care. It's a foundational alternative payment model for delivering patient-centered, longitudinal, and coordinated care. Dr. Kavita Patel is the proposal review team lead, and I'm going to turn it over to her. Oh, like I said, we need to do introductions and disclosures, and I'll start with myself, Jeff Bailett. There's a process, everyone, as I said. That's why we have good staff here to remind me. So Jeff Bailett, Executive Vice President for Healthcare Quality and Affordability with Blue Shield of California. Tim.
Tim Ferris.
Oh, no disclosures, sorry.
Tim Ferris. I practice internal medicine at Mass General Hospital, and I'm the CEO of the Mass General Physicians Organization.
You have a disclosure there, Tim?
No disclosures.
Take the rust off this group here in a second.
Grace Terrell. I'm a general internist, part of the Wake Forest Baptist Health System, and CEO of Envision Genomics, and I have nothing to disclose.
Harold Miller, CEO of the Center for Healthcare Quality and Payment Reform. I do have a disclosure. Some years ago, I can't even honestly remember when right now, although I remember it was an icy day in Kansas City that day. I gave a presentation to the AAFP board. It was 2009, I guess I do have that down here. And I gave a presentation at the AAFP Annual Leadership Forum in 2012. I received travel reimbursements from AAFP for those 2 trips to Kansas City, and I received a speaking fee for the presentation in 2012. I have no current or recent financial relationship with AAFP, and I had no involvement with this payment model.
Paul Casau, cardiologist and executive director of New York Quality Care, the ACO for New York Presbyterian, Weill Cornell, and Columbia, and I have no disclosures.
I'm Bruce Steinwald. I have a small health policy consulting practice here in Washington, D.C., and I have nothing to disclose.
We also have the Vice Chair, Elizabeth Mitchell, on the phone, so I'm going to open it up for her to introduce herself and then disclose.
Thanks. Elizabeth Mitchell, Network for Regional Healthcare Improvement. Nothing to disclose.
Thank you. Len?
Lynn Nichols. I direct the Center for Health Policy Research and Ethics at George Mason University, and I have nothing to disclose.
Hi, Kavita Patel from Johns Hopkins and Brookings Institution, and I have worked informally with the AAFP in the past and attended sessions that they have sponsored, including sessions on payment reform, but I have not participated in the development of this proposal in any way. I have also had working relationships with some of the DC AAFP staff, including working with several individuals prior to their roles in the AAFP.
I'm Bob Berenson. I'm a fellow at the Urban Institute. My disclosure is that as a fellow at the Urban Institute, I have been funded by the AAFP to do analysis of payment models. The last such project was about 4 years ago. I recently was part of a failed bid in a response to an AAFP RFP on single payer analysis. I had no involvement with development of this AAFP payment proposal, and now that I've read the proposal, I do want to do an additional bit of information to the committee, which is that they have identified the Goro et al. Paper as a basis for their proposal. I was the second author on that paper. I come to this meeting with a predisposition to like this kind of a payment model, but I will have a number of questions that I'll be raising about it. So they do cite me as basically as a basis for their proposal, and I just wanted people to know that.
I'm Rhonda Meadows, Executive Vice President, Population Health, Providence St. Joseph Health. I do have a disclosure. I have not had any involvement in this proposed model. I am, however, a family physician, proud to say it, proud to shout it. I am also a member of the American Academy of Family Physicians and have been so for many years. We will not be counting. This model would have no special or distinct effect on me other than as part of a class, and I am not currently practicing medicine. Thank you.
Thank you, Rhonda. We're going to go ahead and let the staff introduce themselves, starting with Sarah.
Hi, my name is Sarah Salinich. I'm an analyst at ASPE, and I help support the PRT that reviewed this proposal.
And I'm Mary Ellen Stallman. I'm the ASPE staff lead for PTAC.
And I'm Ann Page. I'm the designated federal officer for this committee, which is a committee governed by the Federal Advisory Committee Act, FACA.
All right, thank you. Kavita, you're on.
Take it away. All right. I'm going to refer to this as APC, APM, just for the sake of brevity. And I'm also going to make, just so that we can get to discussion, assumptions that everybody on the PTAC has read through our PRT report, so I'll only bring up highlights that are relevant. And just in general, I'm going through, sorry, this is the these are basics on the PRT. You can read it at your leisure. All right, so in summary, the proposal in front of us has key components around payment, an APM entity that would be a primary care practice, and a payment methodology that I'll just point you to the slide because it actually divides the payment into 4 parts. And of the 4 parts, each one of them has different permutations to them, with the first part, a risk-adjusted payment per beneficiary per month, a PBPM for E&M services, at which point a practice could decide that they could receive that prospective payment for office-based E&M services or include all E&M services regardless of site of care. That's the first part. Second, a risk-adjusted PBPM payment for care management services delivered by the practice that are generally not face-to-face, and there are some examples in the actual proposal and in our submitters' responses to our questions. Then third, a prospectively awarded incentive payment, to kind of think of it as a performance-based payment that might have a clawback aspect or might need to be repaid depending on the practice's actual performance on selected measures. And then finally, continued, think of it as kind of the fourth element is really kind of a continuation of current state fee-for-service payments for under the Medicare physician fee schedule for things other than E&M services that are not included in those first 2 payments. So if that, I'm sure that we will get into further details around that, but I wanted to just offer that as like a basics of the payment. Quality measures, I mentioned already. The APM entity, again, potentially a practice, would select 6 quality measures, including at least 1 outcome measures. In addition to that, there are actually 2 utilization-based metrics, ED and inpatient hospital utilization, on top of these 6 kind of selected measures. And then attribution, risk adjustment, the use of HIT. So given that very brief overview of a proposal, you can see how the PRT evaluated, and I'll break through each one of these so that you can understand some of our thinking. And in general, the key issues that we grappled with at first were to really try to understand the distinction between this submitter's proposal and the current frequently cited Comprehensive Primary Care Plus initiative. And for those of you that are not as familiar with CPC Plus, we actually do have some transcripts with CMMI that kind of go through that. However, what we did do in our back and forth, also included in your packet, are kind of clear distinctions, and we as a PRT felt that the submitters identified and articulated a clear need for opportunities in primary care that are not currently or would not potentially be currently met by the CPC Plus program. We did note concerns in the model, and we also will go over some of those, including attribution, primarily patient choice, as well as I mentioned already the 4 levels of payment, but the first one has kind of 2 options within the first level, and then finally kind of this issue of the performance-based payments and the quality. So let's go to criterion 1, scope, which is one of the high priority. The PRT determined that we would meet this criteria, and it was a unanimous decision. And in general, as I already echoed, that this would allow for more opportunities, and in fact the submitter estimated that there could be potentially an impact of up to 80,000 physicians that could potentially participate in this, and a number of Medicare beneficiaries. This is a multi-payer model, so there is also an impact beyond just the Medicare program. And just to kind of highlight some things on this slide, it would completely replace E&M services with a flexible monthly payment, which again is kind of a novel notion, and also enable patients to explicitly choose which practice is accountable for managing their care, which is not currently in the Medicare system. The second criterion, quality and cost, also a high priority. The majority of the PRT felt that we met this criterion, and I'll talk about kind of where we thought there was some uncertainty, just to highlight. So we found that the focus on, there was an emphasis in the proposal on delivery transformation, practice transformation, as well as kind of a notion that is embedded in research to show that if there are increased financial resources in primary care, that there would be an anticipation in improvement in quality, as well as a reduction in total health spending. However, one of the issues that we contended with was that we couldn't necessarily assure that an increase in payment in primary care would always be balanced by a proportionate amount of savings. So there has been some literature and some models that demonstrated this, but it was certainly not something that we could assume would be part, and in fact, in looking at total metrics, we talked about inpatient and ED utilization. There were no other ways to think about total cost metrics within the submitted model. And then the other aspects around quality in particular were that even though the quality measures were reflected to align with the MIPS program and MACRA, it's possible that an entire primary care practice could select quality measures around one discrete condition, for example, and that might not necessarily reflect improved quality for an entire population. The third criterion, payment methodology, high priority. The majority of the PRT felt that the submitter met this criterion, and I don't want to highlight, again, kind of what the positive attributes were, but things that were problematic that I just want to point out, that there was this conversation about the complexity of a patient election, and if anybody on the PTAC wants us to walk through what the submitters have proposed, I can point you to that. But basically a patient election as kind of an initial attribution, but then in addition to that, a claims-based attribution. So mixed methodologies that could be overly complex or also lead to potential selection biases. And then there was also, as I mentioned, this potential for a clawback payment if a practice did not perform as expected on these quarterly incentive payments around quality. There could be some money that needs to be recouped by a practice. And when we're talking about thinly infrastructured or thinly resourced primary care practice, it could put participants in a more susceptible area. And then again, the issue of kind of multiple payment methodologies, multiple PBPMs for non-face-to-face and face-to-face, and that could also be complex. Criterion 4, value over volume, unanimous decision by the PRT that the submitter met this criterion, and highlighting just some key points for you. Risk-adjusted monthly payment. There was a novel aspect to the risk adjustment, which included, without as much detail as we needed, but included some allusion to social determinants being part of that, performance-based incentive payments, as well as, again, this notion that an increase in primary care spending would actually result in better value, both in terms of quality and in terms of cost, and that patient payments are no longer tied to kind of face-to-face or direct patient contacts. Let me just move on, just to get through this. Fifth criterion, flexibility. We also were unanimous in that the PRT felt that the submitter met this. We talked already previously about the flexibility of the payments, as well as the flexibility of the practices to kind of choose which option they were based on whether the practice was in a largely office-based E&M setting or did things that were not in an office-based setting. I'll stop there, and then I'll see if anybody else in the PRT later wants to add. Criterion 6, ability to be evaluated. Let me give a little more color because we unanimously felt that they did not meet this criterion. So in looking through the proposal, you'll see key points where the submitter talks about the ability to evaluate potentially against other practices, similar to what the Comprehensive Primary Care Plus model does. You'll see both in our discussion with the submitter as well in discussions with CMMI that one of the aspects that lent the CPC Plus model to be evaluated was its pretty strict control about which regions it could be deployed, as well as the ability to find kind of comparison groups for those practices. In the submitter's proposal, we could see that it could be problematic given how expansive the payment model could be, that it would be hard to potentially establish valid benchmarks, especially if we're using the hypothesis that increased upfront primary care spending would lead to kind of better downstream utilization of resources. And we also think that just given, again, those multiple payment tracks that someone could follow, one could imagine that in order to evaluate potentially a practice that's in a particular payment track, creating any sort of control group or comparable group from which to be evaluated could be very complex. So I'll just stop there because I think that might generate more discussion. Criterion 7, integration and care coordination. We unanimously also felt that it did not meet this criterion. The proposed model does cite in very specific areas the joint principles of the patient-centered medical home, and if you read through those principles, there is very explicit language around care coordination, but there is this assumption most of the practices would be adherent to these joint principles, and therefore they are coordinating care. But there are no specific called out requirements around the measures of care coordination for individual payments. You'll see in our back and forth with the submitters that we also addressed about the kind of the issue of care coordination outside of the practice, and we discussed, they responded to our question talking about how there is not a clear measure for coordination with providers who would be outside this APM entity. In fairness, the submitters did express that they would be open to that. They just did not have that explicitly included in their proposal. Patient choice, criterion 8. We also felt unanimously that it did meet the criterion for patient choice. In fact, while we identified this process of patient enrollment as a potential complexity, it obviously offers kind of the most robust option around a patient choosing. But we did want to point out that this was just needed to be mitigated, and we just wanted to mention that we wanted to, and we had a conversation with the submitters about kind of stinting of care or unintended worsening of disparities, especially in key vulnerable populations. And so that was something that we called out, but we did feel unanimously like it met this criterion. We also felt that it met criterion 9 unanimously, patient safety, in terms of being flexible around resources that could be mobilized by a primary care physician to deal with issues or adverse events for patients. And because payments are going to be risk adjusted, and I'll call to the PTAC that they actually talk about kind of 5 tiers of risk adjustment based on using a risk stratification tool as well as HCC scores that would allow for patients with multiple health problems to be adequately paid for as well as adequately measured. Final criterion also was met. Oh, did I just skip through? We don't care about 10? Okay, maybe we do. All right, criterion 10 is not on here. HIT, How ironic that it's not on the PowerPoint. Okay. We were unanimous in that it met the criterion for HIT. The proposed model did require that at least 50% of the APM entities participants used a certified electronic health record. And in fact, I mentioned a novel, this kind of notion of novel inclusion of social determinants measures. The submitters went through a little bit of a description of how hopefully electronic health records would help facilitate the collection and categorization of those novel social determinant factors. So let me just stop there. I was really fortunate to have Harold and Tim as part of this team. And I just have to say, I think we started this process as a PRT about 4 or 5 months ago. So we've had lots of conversations, as you can see. So I'll stop there, Mr. Chair, Dr. Chair, Mr. Dr. Chair, and see if Tim, and I haven't had enough caffeine, see if Harold and Tim have any additional comments.
I don't have anything to add. Thank you for doing that.
I would just add 2 things, I guess. It has actually, we worked on this for, I think, actually 6 months or more because the submitters asked for some more time to be able to respond to some of the questions and had some questions about our questions. And we did burden them with many questions. I would just observe that we were, I think, pretty clear on the conceptual structure of the model. There were a lot of details that are missing from the model. I will say, personally, I was disappointed that there was not more resolution to some of those details in terms of how much would the primary care practice be paid, and was it enough to support their operations? Exactly how should the risk adjustment be done? And what was the quality measure framework? When you look through the proposal, it's sort of, in some places it'll mention a measure, and in other places it won't mention the measure. So there was not sort of a really clear, precise thing. And there was, in our conversations with them, some evolution of thinking, obviously, because some of the things that we heard on our call reflected some changes. And that's okay, but it was a little difficult, I would say, at least from my perspective, I won't speak for my colleagues, difficult to evaluate some of the criteria simply because those details really weren't there in the way one would like. And I would just say, I think that given the length of time people have been working on primary care models, I was a little surprised that it wasn't more specific than that at this point.
Grace?
So part of a conversation we had yesterday at another evaluation was around the issues of trying to make this fit across a broad spectrum of types of practices, and how that may be impacting the way things are coming to the PTAC. Based on what you just said, Harold, that you were disappointed that there was not more details, we may need to ask this to the presenters, but do you believe that is because of the need to give broad principles for which it can be over a broad type and category of, in other words, making it generalist enough for different types of practices, or is there something else underneath it?
No, I think it was exactly the opposite. My concern was that the representation was that a primary care practice should get some percentage of total payer spend, which didn't necessarily say to me that that was enough for a primary care practice to be able to deliver the desired services. I think it'd be better to have some analysis of what it would actually cost a small practice, a large practice, to do what was necessary to be able to succeed in the model, and then base the payment on that. So that was, it in fact seemed to me to be a little bit too generically stated rather than to reflect potential differences in practice needs. And the risk adjustment of the payment was based on HCC scores with an openness to do something else rather than a reflection that there might be practices who have different patient mixes that really might need something different than that. So that was, I think the concern was it might have been, in my perspective, a little bit too generic in that regard.
They did offer, Grace, just so you could see, they did offer kind of two different, they accounted for different types of practices in some of their examples, and also kind of took into account, like, you could be in a large integrated organization. So in that respect, they did something that I think we talked about as a PTAC yesterday, where they tried to include kind of branch points depending on, kind of where you kind of meet you where you are. However, as I noted, we also identified that as potentially a problem around evaluation, as well as just, I think what Harold's getting to is that you can see in our transcripts and questions, we were trying to really get a more granular sense of if you firmly believe that you should, let's say, double, which is proposed, kind of the percent of Medicare dollars that are spent in primary care because of this downstream, how would this actually work, not just in Medicare, but because it's a multi-payer model in the commercial setting? And that's where there was a lack of that detail in our discussions, but it's probably something we should ask the presenters.
And I would just add, I mean, none of that says that we in any fashion thought it was a bad model. I think we thought it was a good model, which is basically why we thought that it met all the criteria that we did. However, it was, and in that respect, as good as many other things, but I think that there is at least some concern on my part about whether the lack of specificity leaves open some gaps that might make it difficult to implement successfully in some places.
Len and then Bob.
So, two questions for the PRT. One, when you talk about this lack of detail and how you were somewhat disappointed that you didn't get more detail in the back and forth, do you think that's because they expect these details to be worked out in kind of a testing framework with CMS and they're really looking for technical assistance, or they know that you can't have one set of parameters that fit every practice in this great big land of ours, and so you're going to have to calibrate? I mean, I'm just trying to explore why you think the lack of detail is still in the model.
I'll start. I mean, there's some aspects that are alluded to that they say are proprietary. So I think that was part of the lack of detail. And then it wasn't necessary. I'm not sure if it was technical assistance. I'm not going to make assumptions about what the AAFP can do, but I think it was also just kind of trying to understand how to put together a very complex APM in a constrained amount of space. And so it was our back and forth, you'll notice.
Surely our 20 pages isn't the problem.
Plenty, is not the, no, exactly, it's not the, but it was,
okay.
This is a large model.
Yeah.
With, and I was wrong about, with 200,000 physicians who could potentially be in this and 30 million Medicare patients. To be honest, I think it's the largest model in terms of that type of impact or participation that we've seen. And so I think it's a combination. That was my perception.
Okay, my other.
I would say you should ask them, because I'm not, honestly, I couldn't understand that, to be honest with you. I mean, it's in my perception different from other people who are for the first time thinking about PAM models. There's been a lot of work done on primary care medical home.
Okay, thank you. So the second question, I was, I guess not shocked, but a little bit surprised at the evaluation judgment, that it was not evaluable. And I guess I get totally why it would be complex to find a pure control group. But in those circumstances, I and lots of others long before me used something like step wedge, so you could design.
Sure.
So did y'all consider step wedge as an evaluation strategy to work in a place where you can't get obvious control groups?
Let me start, but I know Tim and Harold will want to chime in. So in fact, Len, you're exactly right. We actually got to a point at a PRT where we were considering how they should have put in details about the evaluation and felt like this is a recurrent theme in the PTAC. We had to kind of listen to what they had. So we started to engage with the submitters in our phone conversations, but still felt, and again, you'll see much of this is a reference to the CPC Plus. So a lot of the methodologies are carried over, but then built upon. And we did not feel that they actually went through how we could evaluate this. And to be honest, kind of, you can see our transcripts with CMMI, Office of the Actuaries, that same concern was reinforced. So I'll just say that's from my part.
So, as you pointed out, Len, you can evaluate anything. So, against, like, how good is the evaluation? The two questions that I think I was focused on was, there is some good evidence as Kavita said, that greater investment in primary care can bring down costs. But the critical piece of this is, can you evaluate in the context of this model whether or not costs are either the same or you bring them down? So the control group issues was one thing, but the other thing was the attribution model, how you enroll. And you're really left with a case-finding methodology, however you do it, stepwise or prospective controls. But it's got to be a matched process. And how do you match on propensity? How do you match on all of the, like, you can do it. I say, how do you match? There are ways you can do it, but it's not perfect. It's not even close to perfect, right? And so I would say it's a you're left in a suboptimal position. Doesn't mean you can't do it. And that's why Kavita said we were imagining ways we might do it. So whether or not it meets criteria is one of these things that is our particular challenge, which is you might restate it and say it's seriously challenging to do this. Does it mean you can't do it? Of course you can figure out some ways to do it, but I wasn't convinced that given the design of the program, that if someone published on a match control basis cost savings based on this design, I wasn't convinced that I would be able to look at that with great confidence and say, yeah, it's working.
I'll just add two nuances to that. First of all, there were, at least in the proposal as proposed, there were so many different options that people could pick that it was hard to make a judgment about how you might really say, so somebody picked to have all E&Ms and somebody picked not all E&Ms. Well, why did they pick that? And how would you figure out how they picked that, et cetera? That's number one. Number two is, I might look at it and say, great model, I'm perfectly happy with it, but there is this little problem called the actuary, which tends to have a somewhat conservative view of things, right? So, somebody might look at the evaluation and say, I'm comfortable with that, but when the actuary's office is saying, we have to certify this, I think there is a concern about whether or not all of that would potentially jeopardize the ability to say, yes, it worked from the people who have to make that decision, so.
Okay, I would just add for the record, I think this is one of those criteria, independent of this particular proposal, that in a way, the phraseology of the criteria from the Secretary's or from the statutory language, can it be evaluated, ability to be evaluated. It's kind of a lot to expect the applicant to come up with the perfect design. I think it's kind of on the professional realm. I take it that propensity score matching would be
that's fair
controversial, but it is in a
fair.
sense hard for the judge. No,
and we actually feel like that same statement, by the way, Len, is applicable to many of these criteria.
Yeah, but more for this one.
Sure, including value over volume, and anyway, so we would echo that for some of the other criteria as well.
Bob?
Yeah, I will start by saying that I practiced under this model 30 years ago, primary care capitation, basically. This is improved because we now have better tools on performance measurement and risk adjustment. But I want to emphasize what sort of brought it down to some extent, or at least the perceived weaknesses, and sort of, I still have some concerns we haven't satisfactorily addressed it. And item number one is this issue of stinting under capitation with a PM to a primary care physician. In fact, and I want to ask if you had any discussions with the proposers about the fact that the large majority of states prohibit primary care capitation outside of an HMO because of the concern that the physicians have too strong an incentive to not provide care. So that, I think, affects the potential of having multi-payer demonstrations. My understanding is that it even affected the willingness of private payers to participate in CPC Plus to some extent, but here this seems to be a pure global payment, comprehensive payment, capitated payment, and I think that would be an issue. in reading what they were proposing as performance measures, and in the response on what would protect against stinting, I wasn't convinced that that would be satisfactory. I didn't see any measures of patient experience, for example, which strikes me as sort of essential in a primary care, for any primary care practice. It looked like they could pick 6, and they could all be very clinically oriented, and they could be for one condition, so sort of nothing about patient experience, nothing about referral rates, which is the easiest way to get around capitation incentives, is to just refer everybody. Now, there are some measures around ER use and hospitalization, so for some conditions you probably have some self-protective mechanisms, but not for many sort of routine patients for whom the easiest thing to do is to just refer them out. So I guess my question is, how much attention did this concern about stinting get? I mean, the response I read in the Q's and A's was basically, we won't cherry pick because this is a patient selection problem, and so we don't get to just pick the healthy people. But then the next one was stinting. We don't want to lose our patients, so we're not going to stint. Well, you put the two together, and you stint on high-cost patients. So I wasn't satisfied that they had addressed that issue, and I wanted to know if the PRT had sort of explored this, because I didn't really see it in your report, the adequacy of the measures, the adequacy of the protections against the stinting concern that state legislatures have prohibited. I mean, they were so concerned about it 20 years ago that they actually banned the practice.
So let me take that last part first, Bob, because we actually asked ASPE and our subcontractors to kind of explore, and then we actually did bring this up with the Office of the Actuary, and we couldn't find any current kind of prohibition. So we did actually try to kind of get to the bottom of that issue around state-based regulations and could not find any kind of examples of that. But I know that
I can refer you to where you can get that information.
Well, you know, since it's the PTAC, we couldn't ask you. So but we did talk about it and tried to explore and look into it. And then I'll just say, I think this issue of stinting, I kind of talked about areas which we felt like we did, you know, were significant weaknesses, and you're hitting on kind of the issue of stinting, but it's brought up things that we have specifically called out. They did, as you mentioned in this kind of back and forth, address this issue of stinting in kind of 3 ways, which I think you've covered. I think we should have the submitters weigh in on this more deeply, but we did bring up a significant amount of concerns around kind of the patient selection piece. We brought up the example around the measures could all be even in one very specific kind of condition and therefore not actually get to some of these other issues. And then I would say the other thing in their response that we discussed as a PRT is that you'll recall that part of this 4-pronged stool, so to speak, is that 4th element of kind of retention of the Medicare physician fee schedule. And that is something that they brought up as one of the like fail-safe mechanisms to be part of this. But I do think that we would benefit from hearing this from the submitter directly on that.
Ask one more now and then wait for the submitters. The proposal that I read said there wouldn't be claims, and for risk adjustment somebody would have to go into the medical record to get information. I think the experience with Medicare Advantage, which is clearly a different situation of not requiring encounter data, and from commercial insurers who pay providers on capitation, are that you have to have encounter data. You can't not. To be able to do risk adjustment and to be able to know if there is actual stinting on care. Did you talk to them about this sort of notion that there would not be either no pay claims or encounter data? And did you have any views as to whether that was okay?
I don't recall that we brought up specifically the lack of encounter data, because as we read the proposal, those prospective monthly payments would also be accompanied by some level of measures. Now, whether those measures are adequate or not, that's a question we should bring up. But I don't recall us talking specifically about the encounter data. Do you, Tim or Harold? I can't.
I mean, I think that's going to be an issue. Even Kaiser has, which is the fully capitated medical group at Permanente, is now collecting encounter data and using CPT codes and the whole thing. And as much as it would be nice not to do it, I think that's a real operational issue about it. And you know, what I saw, they were very vague about how the medical record would be used, I thought.
Well, this gets more, I would say, to some of this issue of the details of implementation, because the practice could potentially bill for its monthly payment for the patient. And they could indicate on that monthly bill, I'm billing for Grace, she's my patient, and Grace has the following set of comorbidities, and that would be how you would do it. As it would only be if it was a pure, and that's, they didn't make that clear as to whether or not this is all calculated at the plan level and coming down to the practice, whether the practice is billing for it. So there could be multiple ways of doing that, but I think we should ask them what they're thinking. And
no, but I guess my point is that in this, I mean, I agreed with you completely that there's a lot of operational moving parts, and that's why I sort of think that the idea that this becomes where all of the primary care docs who are not in CPC Plus because it's limited have an opportunity, I think we should reconsider that. I think there's a lot of detail in getting this right. I think it's worth getting right, but it has to be a fairly well-contained demo, in my view, not open to tens of thousands of primary care docs to work through these issues. It would be great if we didn't have to rely on encounter data and could rely on medical records to provide the information. But just specifically, I don't think it's just about diagnosis. I think it's around services provided to be able, again, to monitor stinting. I don't think at least the measures that were mentioned will get us there. So I'll stop at this point.
Thank you, Bob. And I've got Elizabeth on the phone. She has a question. Elizabeth?
Hi, thank you. My question was around attribution and your concerns about sort of patient election. And I did want to acknowledge that I was on the LAN work group that had identified patient-identified attribution as the sort of optimal approach that the submitters cited in their response to the PRT report. And I had seen this work in commercial settings with employers and private purchasers. Was your concern primarily around implementing this with Medicare, and how does it relate to your concerns about the lack of encounter data?
I'll start. So part of this was our concerns were not just the setting potentially with stinting or some of the issues that Bob even raised in his previous question, but if you actually look at their complete attribution methodology, it starts with patient enrollment, and then there's a plurality-based component that's retrospective. So just even that mixed methodology is complex. Again, we thought that in the spirit of like, could even a large practice do this? It could be seen as administratively complex and confusing. And we know that at least in the Medicare experience, for example, the CCM and things that require that level of patient enrollment and engagement, that has been complex in the Medicare program. So we know this is not the CCM, but if you consider that this would be even broader in its mandate, that was something that we thought would be important to consider.
Yeah, I'll just add, I would have been very positive about it if it had simply said this is going to be for patients who have signed up. But it's a really complex four-part structure. It's patients who sign up, and then if they haven't signed up, if they came for a wellness visit, and if they didn't come for a wellness visit, then it's a plurality of E&Ms. And then if it's not that, then it's if they got a couple of pharmacy claims or a DME claim. And you say, so who all might show up in that? And then when you get to the point, I mean, evaluability aside, I mean, sat with primary care docs complaining about the challenges of simply trying to take their attribution lists from payers and try to make sense out of them every month. And this is describing somebody having to figure that out for these 4 different criteria. So that was the real concern, was the complexity of that from the practice's perspective, and the uncertainty about exactly what kinds of decisions that might lead one to make about which patients one had and one didn't, and would one send patients off for excessive numbers of specialty visits in some cases simply to avoid having them attributed to you or whatever.
Tim.
So I just wanted to add to that. I think what you're hearing from the PRT, and I'm just speaking for myself here, is that in multiple areas of this proposal, the submitters actually had thought through in a lot of detail how best to manage the care model that they were trying to support, recognizing the complexity on the ground of all these moving parts. And what we struggled with was that complexity, recognizing that complexity on the ground and translating that into something that was that you could administer, right? And that's a problem that everyone who thinks about policy is dealing with, right? The real world is actually really complicated. They tried to mirror that real world in certain ways. Almost everything they propose has 4 different ways of doing it. And so as a PRT, we were struggling with all those interacting parts, and then how do you project what's likely to happen? And you're really sort of left with, wow, there's a lot of moving parts here. And it's really hard to say what would happen.
Bruce?
When I read the proposal and sort of sat back and thought, I was having trouble appreciating the added value of a second or 2 per member per month payments. I wonder if the PRT discussed that and could help me understand if you appreciated the added, certainly there's added complexity, so is there added value that exceeds the cost of the added complexity?
I think that's why we pointed it out as a weakness, in fact, kind of the 2, PBPM payments, and that potentially they are not necessary, and it does make it overly complex. I do think this is a better question for the submitters, because they do describe that world of that second bucket of payments is to account for the kind of non-face-to-face care and a lot of the services that are, telephone calls, et cetera, that right now in the kind of existing schedule would not necessarily capture in an office E&M or another E&M. But we brought that very point up as a weakness in different parts of the proposal.
And we're speaking for them again, but they did say that they didn't think that was a critical element, and they did think that even if it was there, that ultimately it would merge.
Go ahead, Len.
I decided I was at risk of speaking for them, so I will wait and let
All right, very good. All right, Grace, please.
Getting back to some of the things that Bob was talking about, one of the things that strikes me in this conversation has to do with us as opposed to the proposers, and that is, as we've gone through the criteria and all these different models, one after the other, what we've accepted as being okay from the criteria 10 as it relates to health information technology is if they're on a CERT EMR, then they're good. I think that's been across the board. But the conversation that we're having now implies to me that we as a committee may need to think about that a little deeper. So, for example, as Bob was talking about stenting, it's not 30 years ago in capitation, and there's a lot that's been learned by organizations such as CareMore that worked on care model design to come up with how you might take care of patients who have a higher risk. We know that ACG from the Hopkins that's been used for 30 years all over the world is the best in terms of predicting outcome, and that there's never been any encounter data that matches that old-fashioned claims data that's been around forever. So these types of questions may be getting partly at what Harold was talking about with respect to granularity on their part, but to Lynn's point, it's 20 pages. There may need to be a different level of engagement that we have as a PTAC with respect to models that have complexity, such this one does, and what we need to be expecting out of health information technology as meaningful to new payment models. So it's a thought.
Bob?
Just picking up on that, this is very complex and will be I think a lot will be learned in actually operating it. And as Len said once, I forget in what context recently actually, that what you try to do here is move it forward. Don't get it all exactly right. The PTAC can't get it all exactly right. Does the concept have enough stuff that we should move it forward so it can go? So I'm thinking that what we need to do is make a decision as to, does this model have enough promise that it needs to be tested, and then identify a number of the operational issues that have to be explored, but not come up with our suggestion as to how to do it right, because I don't think we know, and I don't think they know, but that there are issues that are easily definable that need attention, and so I'm with your sentiment, Len, that that's what our basic obligation here is. Does this have promise, but not to dot the I's and cross the T's and make decisions on very technical operational issues that the demos themselves will tell us what the right answers are. So I just wanted to say that now.
If I could, I would just,
please,
I would just very briefly acknowledge that my basic idea was our role is to serve as a filter for the professionals. And the question is what is brought to us good enough to engage the professionals at CMS? Because they have to do this, we can't.
All right. Seeing no additional comments, thanks to the PRT for sorting through all this and teeing it up for us. I'd like to invite the submitters up to the table now, please. We have no one on the phone. The full team is here in person, so thank you all for coming. If you could just turn your placards over, introduce yourselves, and then you have 10 minutes to address the committee. Thank you.
I'm Michael Munger. I am a practicing family physician in Overland Park, Kansas, and the current president of the American Academy of Family Physicians.
Welcome.
Good morning. I'm Amy Mullins, a family physician and medical director of quality improvement at the AAFP.
Welcome.
My name is Kent Moore. I'm on staff at the American Academy of Family Physicians as a senior strategist for physician payment.
Great, thank you.
And good morning, I'm Sean Martin. I'm a Senior Vice President of Advocacy, Practice Advancement, and Policy at the Academy.
Super. Please.
Well, first, I want to thank you for inviting us to present the APC APM to the full PTAC. We appreciate the time that the PRT, Dr. Tim Ferriss, Harold Miller, and Dr. Kavita Patel have dedicated to a very productive dialogue with our team, and we believe the model is stronger for it. The American Academy of Family Physicians is a national association of family physicians and medical students. It's the largest single specialty organization in the country with 129,000 members located in all 50 states, territories, and internationally. We were founded in 1947 to promote and maintain high-quality standards for family physicians who are providing continuous, comprehensive, compassionate care to our public. The shared goals at the heart of MACRA were to enhance the quality and sustainability of our healthcare system. And it's difficult to achieve these shared goals independent of primary care, which plays a foundational role in the healthcare system and is often the first and most frequent point of contact for Medicare beneficiaries. Family physicians conduct 1 in 5 office visits in this country. That's 192 million visits annually, or 48% more than the next highest specialty. Now, given the reach of primary care physicians, we believe that the PTAC has an opportunity to both increase physician participation in advanced APM significantly, but also to increase beneficiary access to care delivered under these models by advancing this APC-APM. Now, primary care has been on the path for transformation for decades and has built a strong infrastructure to implement the APC-APM. The Academy and its members are not new to innovation in payment and delivery of care, as reflected in the creation and evolution of the medical home and advanced primary care models over the years. As a matter of fact, in our most recent member survey, 47% of our members are actually now practicing in a recognized PCMH, and 30% of our members are in ACOs, with the majority participating in Medicare shared savings programs. The Academy has been active in supporting further practice transformation in the passage and implementation of MACRA so that our members can be competitive and successful in a value-based payment environment. Now, we've done this several ways by providing educational resources and technical assistance to support participation in the quality payment program, supporting participation in innovation center models, including CPC, CPC+, TCPI, to name a few, and by developing this APM, which we believe could be the most broad-based and first primary care-based model that the PTAC recommends to CMS for testing. Moving forward, we are committed to working with PTAC, CMS, and other stakeholders to advance this model, which we believe is a foundational element to the movement of advanced APMs as envisioned under MACRA. Now, the AAFP developed this model based on the need for the physician and patient to work together to improve health outcomes and to help reduce overall cost. Importantly, the model builds on and involves key features of the original CPC and CPC Plus programs already underway and incorporates lessons learned from these and other primary care transformational models. It's important to note that the CPC Plus model is closed. It was designed with high barriers for participation and really was not feasible for many small practices. We designed this model to be more widely available and to reduce barriers to participation for all practices. So for instance, CPC Plus in round one, 2,850 practices, primary care practices, and 13,000 clinicians were enrolled across 14 regions. I happen to be practicing in one of the CPC Plus practices. Our membership alone consists of 70,000 actively practicing physicians and is located in every state and region in the United States, and thus really illustrating the gap between the current CPC Plus program and what this model would bring. Now, we have heard and addressed concerns that this model is similar to CPC Plus, and this model does reflect innovation in primary care. We believe that we have made important improvements on the existing model in many ways. First, this model expands access to a multi-payer primary care advanced APM for beneficiaries and physicians nationwide. Second, the model supports practice and broader system transformation through greater investments in primary care. The model simplifies payment for primary care services and reduces administrative burden for physicians and small practices, especially by moving the majority of payments for primary care services away from fee-for-service to prospective payments that give practices a predictable revenue stream and investments in practice transformation, which is extremely critical for our small and solo practices. Now, while we have proposed multiple E&M levels with the PRT, we do remain open to working with CMS to further refine the approach and address design concerns. Fourth, the model allows for addressing the social determinants of health, which affect health outcomes and cost, and facilitates a true longitudinal assessment of patient needs. And finally, the model uses consensus-based quality measures through the Core Quality Measure Collaborative that aims to drive measurement harmonization and reduce administrative burden to incent greater participation in value-based payment programs. The model includes HIT requirements that can actually support care management through actionable data on patients and their needs. And we designed this model with physician and patient needs at the center. So we're not requiring complex EHRs, but a basic framework and requirements to advance care. The APC-APM is evidence-based and addresses historic problems in primary care payment necessary to strengthen the healthcare system. It creates a more advanced primary care model and supports providers in making changes to care delivery not necessarily supported by the traditional fee-for-service PCMH model. Now, this model strengthens primary care, which Congress and CMS have recognized as essential to building a value-based, cost-effective healthcare system, and builds a strong primary care foundation for the health system by addressing the historic fragmentation and problems in payment. The undervaluation in primary care services and the fragmentation in care partially driven by our current payment system are well understood. Payment experts, including many on this committee, have pointed out that building APMs on a flawed physician fee schedule would simply perpetuate current inequities. Change is needed if we want to improve clinical outcomes, promote prevention in population health, and reduce cost. This model would increase investments in primary care, which MedPAC and other experts have called for. The increased payments would flow through the new payment structure, which promotes continuous, coordinated, comprehensive, and longitudinal primary care. This model is patient-focused and reflects stakeholder feedback and perspective. It has the ability to expand Medicare beneficiary participation in a primary care-focused advanced APM on a larger scale than any other model. At the same time, its multi-payer design can help spread the innovation to commercial, Medicaid, and other markets. Now, while the PRT has raised concerns about how the model could be evaluated, we believe that there are evaluation methodologies that the Innovation Center is already using that could be applied to evaluating the APC-APM, such as those for CPC+. And we'd welcome the opportunity to work with CMS on designing a strong evaluation, which we believe is critical to any APM. In addition, the PRT raised issues with the model driving integration and care coordination. The concept of integrating care and coordinating patient care in a longitudinal and comprehensive manner is at the heart of this model and at the heart of primary care. The Academy would welcome the opportunity with CMS to ensure that quality measures or patient survey data are incorporated to achieve these core principles. And last, our patient attribution methodology, which uses patient attestation as the primary method, reflects a gold standard in patient engagement and was broadly supported by stakeholders. Now, since its original submission, the AAFP has solicited feedback and considered issues raised by stakeholders, including other providers, health systems, payers, consumer groups, and payment and policy experts. We've received letters of support from a broad range of stakeholders underscoring support for the model and its feasibility for testing and implementation, including several of our chapters, such as North Carolina and Colorado, that have significant rural and small practice members, health systems such as Ascension, which has experience implementing a similar model within its system, and other physician societies, including the American Medical Association, the American College of Physicians, and the American Geriatric Society. AAFP appreciates the opportunity to present our model for consideration by PTAC. We look forward to answering your questions and having a good discussion. Thank you.
Thank you very much, Dr. Munger.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.